Record. Okay, so again, good morning, everyone, and also good afternoon if you're in the UK. My name is Abby Beho, and I am the founder and program director at Lake Health and Wellbeing. And just in case you haven't heard of us, Lake Health and Wellbeing is a public health NGO based in St. Kitts and Nevis, and we aim to improve the health and well-being of our local, regional, and online community through research, through public health interventions, through health education events like this, and also we do advocacy work. So it's really a pleasure for me to welcome all of you today to this webinar on fibroids and fertility. And so we've been doing a series of webinars, educational webinars on fibroids. And the reason for that is that it tends to be a women's health issue that tends to be overlooked and neglected. And we just wanted to change this and to ensure that women have the information and support that they need to manage as they live with fibroids. So today, we're focusing on fibroids and fertility. And again, the reason why we're focusing on this particular topic today is that we did a research project a couple of years ago, and women raised a number of concerns around fibroids and fertility. And we just thought it would be useful to have a session that would address some of these concerns. So our guest speaker was going to be Dr. Stacey Bryan, but unfortunately, she has lost her voice. So hopefully she will still join at some point and sort of answer questions through the chat. But we're very, very grateful to Dr. Illah. Sorry, I know I probably pronounced it wrong, who has stepped in today at the last minute. So we really appreciate her. So she stepped in today to present this presentation on behalf of Dr. Bryan. So what we'll do is we'll have the presentation, and then after the presentation, we'll have a Q&A where you can ask any questions that you may have. So you can put your questions in the Q&A box. And if you prefer, because you know that fibroids and fertility tends to be a sensitive topic, you can ask your question anonymously, and you can do that by ticking the relevant box in the Q&A box when it comes up. Many of you did send questions beforehand, so we hope that the presentation answers a lot of those questions, but if not, you can ask your questions. And then just to remind you that this webinar is intended solely to provide information. So the information that's presented as part of this webinar and any materials published in relation to this webinar are provided solely for general purposes only and should not be construed as medical advice. And so you should definitely seek medical advice from your doctor before any action is taken in relation to the information that's provided today during this webinar. So without further ado, I'm going to hand over to Dr. Illah to provide a presentation on fibroids and fertility. So over to you, and thank you so much for stepping in.
Hi everyone, I'm Dr. Illah or OJ. These slides have been prepared by Dr. Stacey Bryan, who was initially meant to give this talk. She will be joining at some point, as Abby has mentioned. So I am a colleague of Stacey. I am a gynecology registrar in the UK. So I've had sort of a few years of experience in dealing with sort of general gynecology problems as well as gynecology cancer problems. So in, I guess, the years of like my career to date, I have quite commonly had to sort of come across and help manage women who have fibroids, whether they've got problems with sort of bleeding, pain, you know, with some of the other effects of fibroids, or women who have been seeking to get pregnant, and definitely women who are already pregnant. So I'll give this talk, which will go over initially just a brief overview of what fibroids are, what they mean, the sort of the different areas that they can affect in the body, the sorts of symptoms that they can cause, and then we'll talk a bit more about the effects of fibroids on fertility and the effects of fibroids on pregnancy and pregnancy outcomes as well. Sorry, I have a bit of a cold myself, so I might be clearing my throat a bit, pardon me. Yep, so as mentioned, we will talk about what fibroids are. We'll go over the different types of fibroids, of which there are 3. We'll speak about the effects of fibroids on fertility, the effects on pregnancy, and also the effects of delivery of a baby, and then what can be done about them to try and sort of improve outcomes from fibroids. So first, what are fibroids? So fibroids are tumors. So they're tumors, so they are growths, but they're non-cancerous. So they are benign growths which form in the muscle layer of the womb. The womb normally has 3 layers. If you can see from that picture there, you've got the innermost layer, which is what we call the endometrium. And the muscle layer is that thick layer in the middle, which is called a myometrium. And that's the area in which fibroids develop. So they're tumors, which mean that they sort of have the potential to grow if they get, if they can be fed, which they are because the uterus has a blood supply. So they can grow. And in some cases, they can undergo what we call a malignant transformation, where they switch from being a benign tumor to a malignant tumor, but that's extremely rare. So fibroids are extremely common. About 33 to 37% of the general population of women will develop fibroids at one point or another in their lifespan. In the Black population, however, the prevalence is much, much higher, up to 3 times higher than it is in the Caucasian population. I'm not too sure what the reasons are behind that, but we do know that where even sort of other ethnic groups, they do get fibroids, but they don't always grow as large, or they get to a certain age where they start to shrink. In the Black population, that doesn't happen at the same rate, actually. It grows sort of at quicker rates and affects more of the Black population than it does any other ethnic group. The most common age group that fibroids affect are women sort of between the ages of 30 and 50. After 50, the majority of women will go through the menopause, and because fibroids are fed a bit by estrogen, when you do go through the menopause, fibroids often usually tend to shrink. So next we'll talk about the types of fibroids. As I said, we've got 3 types of fibroids. These are the medical terms for them, but they just refer to where the fibroids are. That's how we divide what type of fibroid they are. So fibroids that affect, I'm not sure, can you see my cursor moving? I hope you can. So if you've got a fibroid that's in the cavity there, so the innermost cavity of the uterus there, that's the endometrium. If you have a fibroid which lies there, that we call a submucosal fibroid. You've got different types. You've got a normal submucosal like this one, or a pedunculated submucosal, which means it's got a bit of a stalk, which you can see there, but they're both submucosal fibroids. These fibroids probably have the most impact on sort of ongoing fertility and pregnancy, because in this endometrium, like in that cavity, is when, if a woman falls pregnant, that is where the pregnancy will occur. That's where the placenta will attach, and that's where the baby will grow. So when you've got a fibroid, which is a submucosal fibroid, that potentially has it can sometimes affect outcomes with pregnancy. Then going into the next layer, which is the myometrium, that's the muscle layer that I spoke about. So in that layer there, you can get what we call intramural fibroids. So that means intramural means within the wall. So they're within sort of that thick wall of the uterus. And then finally, we have the subserosal fibroid, which are in the outermost layer of the uterus, like that one there. That's a very big fibroid, but that's a subserosal fibroid. You can see that it's not predominantly in that pink, that sort of orangey peachy bits there, which is the muscle layer. It's more towards the external part. So it's called a subserosal, just below the outer layer of the uterus. So that's generally how we divide the, types of fibroids. But you can have any of these types of fibroids affecting any parts of the anatomy of the uterus. So you could have, for example, in this picture, we've got a subserosal fibroid there, which is at the top of the uterus. Just to orient you, I think you probably know this, and sorry if I'm, dumbing it down too much, but just to orient everyone with the anatomy, that middle bit there, this is the uterus that we're speaking about. These are the fallopian tubes. That's one tube on one side, which leads to the ovary. That's the other tube on the other side, which leads to the second ovary. that whole thing there is the uterus, and just underneath the uterus there is the cervix, and then the cervix leads down into the vagina there. Okay, so back to what I was saying, you can have any of these type of fibroids affecting a different part of the uterus. So you could potentially have this subserosal fibroid in this area there, or in this area there. Sorry, my mouse keeps moving to the next slide. Or you could have, you know, a submucosal fibroid in any part of the endometrial lining. And similarly, you could have an intramural fibroid anywhere along the entire sort of muscle layer of the womb. So as you can see, depending on where the fibroids are, they could potentially have different effects. So a fibroid that's there in that area there, which is close to the cervix, for example, could block off the cervix, and that could sort of have an impact on the type of delivery that someone who has gotten pregnant has to have. Because if her cervix is blocked off, then the baby won't be able to pass through the cervix, which is what would happen in a normal vaginal delivery. So we'll talk about all of that a bit more, but then this is just to give you a bit of the anatomy and the background. This would be the why of when we explain why things can be affected later on. So effects on fertility. So the majority of women, I'll start off by saying, who have fibroids will end up getting pregnant without any problems. The majority of women, we've seen women, you know, all the time who have got fibroids, who have successful pregnancies, they carry to term. Some of them have normal vaginal deliveries. Some of them have cesarean sections because of the location of the fibroids. But the majority will be able to fall pregnant naturally. If you look at a cohort of women who have subfertility, i.e., they have got issues getting pregnant, only about 5 to 10% of them will have fibroids. And there are much more common causes of subfertility. So fibroids is not by any means the most common cause of subfertility. Other things like polycystic ovarian syndrome, which we've heard about, other causes of anovulation, which is where a woman doesn't have any ovulatory cycles. For example, you've got male fertility issues that can cause problems with falling pregnant. So fibroids don't by any means represent the majority of issues with falling pregnant. As I mentioned, it really depends on where the fibroid is and how big the fibroid is and how many fibroids there are. So there's no clear-cut answer to, if I have fibroids, can I get, it's not a yes or no, can I get pregnant, will I have problems? It depends on so many different factors. So, you know, with a woman who has fibroids, they need to sort of undergo a thorough assessment to determine all of these things, where they are, what size they are, and what number of fibroids there are. Subserosal fibroids, I'll just go back to the previous slides. That's the one there. Subserosal fibroids have the least impact on pregnancy. And from this picture, you can see why. As I said, in this sort of middle area there in the cavity, that's where most of the pregnancy is happening. We don't sort of, usually have a huge impact from anything which is so far away as where subserosal fibroids are. And then intramural fibroids and the submucosal fibroids. So that's these ones. So these are the submucosal fibroids, and the intramural, which are a bit closer to the cavity. Those can have an effect on fertility and on pregnancy. Okay. So how can it affect fertility? So most commonly, if you just think about it from a mechanical, sort of obstruction piping point of view, when a woman ovulates, so that's the ovary there, the ovary releases an egg. The egg travels on this journey along the fallopian tube, and somewhere along that journey, the sperm that would have been deposited there in the vagina would travel up through the uterus, through the fallopian tube, and meet with the egg at some point in the fallopian tube. And then when that egg is fertilized, then that embryo will move downwards, back to the uterus, back into the cavity, and then it will implant in this thin lining, the endometrium, and then the pregnancy grows, and then that's the magic. That's how it all happens. And so if you have a fibroid, which, if you can imagine, if you've got a really large fibroid, which is potentially blocking off a fallopian tube there, it's difficult for the sperm to actually meet the egg, and it's difficult for the egg to travel the entire distance of the tube and make it all the way down to the womb. And so just by a mechanical blockage, sometimes fibroids can just stop the sperm and the egg from meeting and making the journey back into the womb. Again, as I said, I'll keep reiterating this. It really just depends on where the fibroid is. That will have the most sort of say in how much, it will affect things. So next, it can prevent a fertilized egg from attaching to the lining of the womb. So egg's been fertilized, it's gotten to the endometrial cavity. And what normally happens is that, that fertilized egg implants, it sort of burrows its way through this endometrial lining. So it is sort of fully attached to the lining of the womb. So if you have a submucosal fibroid, like this one there, which is in the way, and that fertilized egg is trying to implant there, then obviously that fibroid is completely in the way and that implantation may not be successful. Changes in the shape of the cervix. Again, this is where location like matters. If you've got a fibroid which is sitting right there, which is over where the cervix is, then that can distort the shape of the cervix essentially and block off the cervix. Increased risk of miscarriage, which yes, we do get with fibroids. And the reason why, again, it's similar to all of these. If you have got a fertilized egg and it's tried very hard to implant anywhere in the lining of the womb, but then you've got a fibroid which is getting in the way, stopping it from implanting, or pushing it away, even if you've got an intramural one, which is just sort of distorting the cavity in a way that it's not a smooth lining for that fertilized egg to implant, then that implantation won't be successful, and then there could be, the outcome of that could be a miscarriage. Similar, so distortion of the shape of the cavity, we've kind of touched on already. So changes of the shape of the cavity, that's meant to be a smooth line. It's not a smooth line because we've got the fibroid there. And for similar reasons, an increased risk of preterm birth, because yeah, again, similarly, you can see the fibroid sort of limiting the amount of space that the baby has got to grow. It's limiting the amount of space that the placenta has to sort of grow and attach. And so there's a chance that, if a woman has gotten pregnant despite the fibroids, there is still a chance that there could be a risk of a preterm birth. Okay. So I guess the sort of 3 different ways that fibroids can affect fertility are that it can stop you from getting pregnant by several ways. If you do get pregnant, it can increase the risk of a miscarriage. And if you sort of go past the safety points of a miscarriage, it could still increase your risk of preterm birth by sort of the effects that it has on the endometrial cavity, and also by something we'll talk about later, which is called degeneration of fibroids. So like we mentioned before, so submucosal and intramural fibroids, that's these 2 there. Those are the ones that have the most effect on fertility because they are directly where embryos implant. So they interfere with implantation. They can interfere, if you can imagine a placenta trying to attach there, they can impede the blood supply. And that can lead to either by mechanical effects of just reducing the space in the cavity, or by affecting blood supply, it can result in inflammation or early pregnancy loss. And then we have also, in addition to this, although quite a complicated interplay of genetics, so genes and other biochemical factors, which are sort of which the fibroid affects, which can then change how receptive the womb is, the uterus is, to actually accepting a pregnancy. And when you do have fibroids, particularly fibroids that live in that muscle layer, then those can, this interplay between these factors, which can make the womb like a less receptive and more hostile place for a pregnancy to occur. So I guess my take home from this is like, yes, the majority of women can get pregnant with fibroids. However, if you've got a fibroid which is in a key location, if you've got a really large fibroid, yes, it can affect your fertility. Now, these are some pictures. Now, just trust me, I think you've got to use the eye of faith here. I know they're a bit difficult to interpret. These are MRI images. What you can see there is a fibroid, essentially, and you can see how it's distorting that cavity and that space a bit where you've got a fetus, you've got a baby growing there, it's just got limited space to sort of move. The placenta has got a limited space to attach, and this pregnancy will not be able to be delivered by vagina because the fibroid is in the way. That person will require a cesarean section. Because that's impeding so much in the cavity and on the way, like where the baby is growing, the baby may be in a breech position, or they could lie in a transverse position. They could lie in a position which is not your typical position where the baby's head is down. And that's because there's just not, space for the baby to turn and sort of move into the right position. And the shape of the uterus, the shape of the inside cavity is not allowing the baby to lie in a head down position. That's a picture. This is a lot clearer. So baby's head, baby's back, and that's baby's bottom there, and baby's legs. That there is the fibroid. And you can see that it's just sort of, it would be really difficult for this poor baby in this tight space to, turn around into a head down position. So this is a breech presentation of a fibroid. But unlike this picture where the fibroid is in the way of the cervix, in this, the fibroid is all the way up there. So actually, this is a breech position. But if it were head down, then there, still could be the possibility of achieving a vaginal birth because the canal is clear of the fibroid. So just some numbers. So in about 10 to 12% of pregnancies, you will see that women have fibroids. That can range from a tiny 1 centimeter fibroid to huge, sort of over 10 centimeter fibroids. And like we've said, because of the effects that the fibroid has on the womb, that can affect the way the baby is lying. So the baby can have an abnormal position or an unstable lie. The lie refers to the way that the baby is lying, whether it's a head down or a breech lie. That's how we refer to it. It could also affect the placenta, because if the fibroid, as I mentioned, is in the way of where the placenta would ordinarily implant, it might implant in a slightly abnormal place, which could be lower down in the cavity, which can cause problems in pregnancy. I don't know if any of you have heard of like a placenta previa, for example, which refers to a placenta which is in an abnormal location. And that can cause problems with bleeding, and that can result in preterm deliveries, and can result in emergency cesarean sections if the bleeding is significant. Now, it can cause pain during pregnancy. I'm sure most of you would have heard about this, where you've got a woman with a fibroid, and what happens in pregnancy, usually most of the time early on in the pregnancy, the fibroids can often grow with the pregnancy, because as the blood supplies increase into the womb and to the baby, to the placenta, like through the placenta, there's also an increased blood supply to the fibroid. And so that fibroid can sometimes grow and get bigger in pregnancy. And then you get to a point where the blood supply to the fibroid is not able to meet its requirements. And so that fibroid, because it's gotten so large sometimes, or even if it hasn't gotten so large, just because the uterus is now focused on something else, i.e. the baby and the placenta, and that's where most of the resources are going, there's not as much feed in the fibroid. And then it undergoes a process called a degeneration, where it's got a reduced blood supply. And it's, if you think about it, it's like a bit of tissue which is becoming a bit necrotic and dying off. And that's very painful. So you can get women in pregnancy who present with degeneration of fibroids, which can be extremely painful, often need to be admitted in hospital for some days and receive strong analgesia. And because that pain can sort of impact the muscle layer of the womb and cause contractions, that can unfortunately in some cases result in a preterm labor. So based on some of these things we've discussed already, there is an increased chance in fibroids of needing a cesarean section delivery. If a woman has fallen pregnant and she has fibroids early on in the pregnancy, it's extremely important to do a detailed scan to map out where all the fibroids are and see what the effects it could have on the passage of, the baby. Does the baby have a free passage through the birth canal? Or does it not? And most of the time, not most of the time, some of the time, it sort of increases, it results in a cesarean section delivery just by blockage of the birth canal. And the final sort of complication that it can have on pregnancy is an increased risk of bleeding, which is what we call a postpartum hemorrhage, after the baby has been delivered, because the fibroid has its own sort of blood supply, and it's quite a vascular growth. And so where the uterus is contracting down after childbirth, you've got that whole area there which is also trying to contract down, and that process causes bleeding. So the majority of women who have fibroids will actually end up having more significant bleeding than women who don't have fibroids. So in women that have fibroids, we normally have to be prepared if they come on the labour ward in labour, or they're having a cesarean section delivery, and we'll normally need to ensure that we've got the right blood group ready for them. We're aware that they could bleed. They need to have an IV line in. So if they start bleeding heavily, we can give them fluids and give them blood quickly, because we know that that's a risk factor for bleeding. It's also a risk factor for needing things doing. If she does achieve a vaginal delivery, the placenta might be abnormally stuck to the lining of the womb and just might require a bit more manipulation to detach that placenta from the womb. So there might be a chance of doing what we call the manual removal of the placenta, where the placenta doesn't deliver naturally. So what are the things that could be done to manage fibroids? So lots of different options. Vitamin D, it has been linked to lots of things. It affects so many different systems in the body, and one of them, not surprisingly, is your fertility. So it can be used, it's always recommended as a preconception sort of part of your vitamins, in addition to folic acid and other normal preconception vitamins. And because there is a link specifically, I guess, relevant to this talk, with a deficiency of vitamin D and an increase in the growth and in the development of fibroids as well. So investigation of other causes of infertility, like I mentioned, fibroids are not the most common cause of infertility. Polycystic ovarian syndrome, weight, lifestyle, male infertility, those are actually more common. So don't assume that if you do have fibroids and you are having issues getting pregnant, that's not necessarily the reason why there are issues, and it's still important to look for these other things, otherwise they will be missed. If, for example, a patient has got polycystic ovarian syndrome, that's PCOS, and isn't ovulating, there's nothing like removing the fibroids, doing anything for the fibroids won't change the fact that pregnancy will be difficult to achieve in that patient. So always think outside the fibroid box and look for other things that could potentially be contributing to the fertility issues. There are lots of medical therapies that can be used to manage fibroids. These can help shrink fibroids or reduce the growth. They probably won't remove the fibroids completely. Unfortunately, most of these in the context of fertility can't be used. So GnRH analogs, that's a medication that sort of it copies the effect of hormone, which is released from the brain. And by sort of targeting that pathway, it reduces the hormonal effects on the fibroid, which can make the fibroid grow. So that's actually quite effective at shrinking fibroids. And we often use it before operations to shrink a very large fibroid. So removing it surgically is easier, for example. That can't be used in a patient who's trying to conceive. It can be used before she conceives, but it can't be used when conception, when a patient is actively trying to get pregnant. The combined oral contraceptive pill can also shrink fibroids by the same sort of pathway, by inhibiting the hormonal pathway which feeds fibroids. But again, that can't be used in in a patient who's trying to get pregnant, because this is a contraceptive. NSAIDs, which are non-steroidal anti-inflammatory drugs. So this is things like ibuprofen or things like mefenamic acid, which can sometimes help deal with pain, and they also help with the fibroid effects. But these also can't be, they're contraindicated in pregnancy. And the Mirena coil, which you might have heard about, which is a contraceptive implant which goes into the uterus, a contraceptive coil. Again, that can sort of make the growth of fibroids static, so stop them from growing any bigger, maybe even shrink them a little bit. But then that will also stop a patient from getting pregnant. Other, I guess, more sort of fun things that could be done is this procedure called a high intensity focused ultrasound, or a uterine artery embolization, which is where basically using imaging techniques, the fibroid is localized and it is targeted. The blood supply could be targeted to block off the blood supply to the fibroid, so the fibroid can stop growing, because if it's no longer getting its nutrients that it requires, then it will start to shrink and stop growing. So these are some less invasive ways before we get to the next slide, which will speak about the surgical ways of removing fibroids. That's just a picture showing that smoking is another, important thing to consider when we're talking about fertility, both in sort of the male and female partner. Smoking can affect fertility. So stop smoking. So other things that could be done surgically, a hysteroscopy and a fibroid resection. Now, this is a procedure where we pass a really tiny tube called a hysteroscope while a patient is sedated or asleep, sometimes unlikely when they're awake, but we pass this through the vagina, through the cervix, and into that inside cavity of the womb. And then we can see the fibroid using that instrument that we've passed, and then we remove that fibroid. Now, this can only be used for fibroids that are inside the cavity, if that makes sense. So if you see this picture there, so the scope, the camera that we insert, it goes essentially through here. And this is what we can see, basically this triangle here. So we won't be able to target a fibroid which is there because we won't see it, or a fibroid which is there because we won't see it. But for these submucosal fibroids, that one we can completely remove by doing a hysteroscopy, which is great because it's not as invasive as doing surgery through the tummy. As you can imagine, if you have a fibroid which is like that one, we probably would only be able to remove this part of it. This part of it that we can't see, we won't be able to do anything about. So it's all about the planning which we do before we choose what type of, operation we offer. We'll have to do imaging scans and determine where the location of all the fibroids is and the best approach to get into them. So the hysteroscopy does, and removal of the fibroids which are in the endometrial cavity, which are the ones, as I said earlier, they're the ones who have the most impact on pregnancy. So doing that actually does improve pregnancy rates. There might be some scarring inside the endometrial lining after you have that procedure, which can sometimes by itself also affect pregnancy and ongoing pregnancies. But that's easily fixed by doing another procedure, which is similar to a hysteroscopy, to remove those adhesions and scar tissue that forms in the lining of the womb. So the chances of pregnancy following a resection of a fibroid, which is a submucosal fibroid, is actually increased by 50 to 60%. We normally say after a procedure like this, leave it about a month for the womb to recover and be in a ready state to receive a pregnancy if a pregnancy happens. And then sort of more invasive surgery is a myomectomy. A myomectomy, so a myoma is what we call a fibroid, and anything which is an ectomy means removal. So myomectomy means a removal of a fibroid. If you've got a small fibroid, which is about less than 3 centimeters, which is about that big, We wouldn't often recommend doing a myomectomy procedure, but anything which is greater than 4 centimeters, it can be done. Not all the time, it's on a case-by-case basis. If you've got a woman who's got fibroids that are over 4 centimeters, but they're not in the way in terms of fertility, and they're not causing any symptoms like heavy bleeding or pain or sort of pressure symptoms, then there's not necessarily a need to remove them. So in intramural fibroids, it's not shown necessarily to increase or improve the pregnancy rates. The procedure itself carries certain risks, and there's a risk that as we try and access, I'll just show you this picture to explain better. The surgery happens, for example, imagine we're trying to get to this fibroid, and instead of going through there, which is what we do with the hysteroscopy, with a myomectomy, we are going through the tummy. And so we've got the view of the outside of the womb. And so we've got to go through these layers until we see the fibroid. And then we try and shave away the fibroid. So what can happen sometimes is what we call a breach of the cavity, where we go all the way through the cavity, and then there's a breach there in sort of the cavity, which can have certain implications for pregnancy, because that's an area where there's a scar, if you think about it that way, where we've gone through the endometrium and there's a scar on the endometrium. And if a pregnancy does occur, then there could be, that area could be a bit weak. And therefore, if contractions are happening in a normal labor process, that area which is a bit weakened can actually open up. So having had a breach of the cavity can increase the risk of what we call a uterine rupture. That sounds quite dramatic, and it is an emergency if it happens, but it is rare. It happens in only 1% of cases. So if you do have a procedure and your surgeon has said that the cavity of the endometrium has been breached, I would very highly recommend that you have a cesarean section delivery if you do fall pregnant, just to try and mitigate that risk. Although it's rare, although it's 1%, you know, if it happens to that one person, for them, that is quite significant, obviously, because that will have implications for both the baby and the mother. After a myomectomy, the recovery period is said to be about 3 months. So after having this type of surgery, not to get pregnant for 3 months, to give the womb time to recover. And with a myomectomy procedure, there's always the chance of a hysterectomy. Fibroids are very vascular, they can bleed, and if in the process of trying to remove these fibroids, we encounter significant bleeding, which is putting the patient's life at risk, we might have to make a decision on the table to actually remove the entire womb. And so that's always something to consider. These are pictures of fibroids that have been removed surgically. That's a very large one, and these are smaller ones. That's what they look like. So that brings me pretty much to the end of this talk. Take-home points are, yes, fibroids can affect fertility, but having fibroids by any means does not make you infertile. And most obs and gynae doctors you'll meet will, I'm sure every obs and gynae doctor has come across a fair bit of, like, quite a lot of patients that have got fibroids but are pregnant and have pregnancies that carry to term, and some of them have normal deliveries, some have cesarean section deliveries, but in terms of the fertility, it doesn't necessarily make you infertile. It depends on the location. It's all about the location, and also, in addition to that, the size, because where it, you know, the different parts of the womb and the surrounding organs have different parts to play in pregnancy. So where that fibroid is will affect what sort of impact it has on fertility and on pregnancy. And surgical options, mainly because most of the medical options don't sort of definitely remove the fibroids. They can shrink them or stop them from growing, but then you would have to stop those medications to try and fall pregnant. So surgical management of the fibroids, either using the hysteroscopy to remove those submucosal fibroids, or a myomectomy to remove the fibroids in the muscle layer, the intramural or the subserosal fibroids. Those have the best effect on achieving a pregnancy. These are the references that were used by Dr. Bryan to prepare these slides. And I believe it's time for questions. Thank you for listening.
Wonderful. Oh, thank you so much, Dr. Illah. That was very, very comprehensive, very informative. So thank you to both you for delivering and to Dr. Bryan for taking the time to prepare the slides. So thank you both so very, very much. Dr. Bryan's also joined us. So hello. And so I guess can assist with answering questions in the Q&A. So we do actually have a question that's come, in fact, 3 questions that come in from the same person. And so I'll just do the first one. So the question is, how large is large enough for a submucosal anterior corpus to prevent pregnancy? So how large?
A submucosal anterior fibroid, is that right?
Yes, yes. So
Okay.
how large is large for it to prevent pregnancy?
It's difficult to say. So submucosal fibroids, even at a small size, unfortunately, because of where they are, even if they're sort of 2-3 centimeters, they can impact fertility. If pregnancy has happened and the placenta has formed and the placenta has implanted, the size of those fibroids, they don't ever get very large because they've got a limited space in which they can grow. So you don't often get very large submucosal fibroids. So if you have been able to fall pregnant and placenta has been able to attach normally, then it's unlikely that that would have a significant ongoing impact on the pregnancy. So it's difficult to say in terms of size, especially for these submucosal ones, because if you've got a submucosal one which is completely indenting into the cavity and stopping a pregnancy from implanting, then the size of it is less important. It's hard to give a fixed number. Definitely anything over about sort of like 3-4 centimeters, I'd say, could potentially affect fertility in that case.
Yeah, wonderful. Thank you for the answer. So the second question is, can fibroids cause brain damage or other physical deformities of the baby that are in small spaces in the womb, as shown in your diagram?
No. A quick answer to this.
Nice,
no.
quick answer. Okay, great. And then the third one is, can surgeries be conducted during pregnancies to remove fibroids?
So theoretically, yes, we can perform the surgeries on a pregnant patient. However, you'd really struggle to find a gynecologist who would do that, because operating on the womb, which is where the pregnancy is ongoing, would carry an extremely, extremely high risk of the pregnancy being terminated or having a preterm labor. If you mean at a point of a cesarean section, if the fibroids could be removed, technically, if they are in the way of the surgery and they're easy to access and remove, then yes, we can remove them at the same time. But at a cesarean section delivery, we won't be looking for fibroids, because we're trying to control the risk of bleeding, and trying to remove the fibroids at that time will increase the risk of bleeding. So the short answer to that is, if you're pregnant and wanting the pregnancy to continue, like it's not yet time for the pregnancy to end, probably no for removing the fibroids, because that procedure would likely result in an end of the pregnancy.
Okay, all right. Thank you so much for that. And then we have a question in the chat, which is, I think, more to do with heavy menstrual bleeding and how to deal with it. So what can be done to lessen the blood flow during the menstrual cycle as a result of the fibroid?
For fibroids, yeah, so there are lots of things. So all the medical treatments that we spoke about could be done. So using, if the person's not trying to fall pregnant, then the use of the Mirena coil, for example, is extremely effective at reducing the flow from periods. So that definitely lessens the bleeding, as does the contraceptive pill. If the heavy bleeding is caused by the fibroids, and using some of these other medications like the GnRH medications can shrink the fibroids, and because the fibroids are smaller, there would be less bleeding from them. As I mentioned before, these medications can't be used in someone who's trying to achieve a pregnancy. So if fertility is desired to be maintained, then the sorts of things that could be used, if you're trying to get pregnant, for example, and in that cycle, you haven't fallen pregnant and you're having a heavy bleed, then you could use things like tranexamic acid, which is a medication which helps the blood to clot more. And by making the blood clot more, the amount of blood that you lose would be less. And using non-steroidal anti-inflammatory medications, that would be things like ibuprofen, or more effectively, things like mefenamic acid. Sorry, these are some long names, but those things would all help to reduce the flow, and they won't have any lasting effects if on your next cycle, after that period is over, you want to try again for a pregnancy. They won't have any lasting effects on the pregnancy.
Okay, great. Thank you so much for answering that question. So any other questions? Any other questions? So maybe while people are thinking, there was a question that came in beforehand, which I thought was maybe interesting and probably useful to answer. And I guess the person was wondering about whether if you have multiple myomectomies, if you have multiple myomectomies, would that maybe have like an additive effect on your fertility? So they were saying, like, what are the chances of them in terms of having a baby? What are the chances? Could they still have a baby after having multiple myomectomies?
Yes, certainly could still have a baby after having multiple myomectomies. If you have multiple myomectomies that have breached the cavity like we spoke about, then we often recommend a cesarean section delivery. But after a myomectomy, things will heal. They often it looks sometimes like we've really had to piece things back together when we've had to remove lots of fibroids, but everything heals, and given a few months, that uterus will retain some sort of a normal sort of anatomy and shape again. So yes, you can definitely achieve a pregnancy, and actually removing fibroids, which can be stopping you from getting pregnant, can actually then actually increase your chances of getting pregnant, as long as it's clear that the endometrium has or hasn't been breached. It doesn't, not that it doesn't matter, it matters which. We just need to know if it has been breached, so that if you do get pregnant, they can plan properly for the mode of delivery. And yeah, that's it. And just giving it the appropriate time period after the surgery to allow the womb to recover and sort of regain its normal anatomy again. But yes, definitely can get pregnant.
Okay, great. And just to confirm, it's 3 months in terms of recovery.
3 months, correct.
Okay, great.
Always, I mean, your surgeon will tell you things, but at least 3 months is what we'd often say to patients.
Okay, great. So any other questions? Does anybody have any other questions or comments that they would like to pose? Feel free.
Feel free.
Any other questions while you have the chance? Okay, so it looks like we don't have any more questions. So I really just want to take this time to thank both of you, Dr. Bryan and Dr. Illah, for taking the time to provide such a comprehensive presentation. It was very, very informative. And I think it's an area that women have a lot of concerns about. So I hope that you've been able to address a lot of those concerns and also address a lot of those questions. And a sneaky little question has come in. So we have another question. So somebody said, my doctor's recommending surgery to remove my fibroids, but I'm scared because I'm trying to get pregnant. I also have hormonal imbalance issues. So I guess any tips or advice that you can give there?
Yeah, so if the doctor's recommending surgery because based on the location of your fibroids, he feels that it's going to improve your chances of getting pregnant, then I'm sure they've got a good reason for doing so. So having a myomectomy, the main thing, which is a concerning thing, is that there is always a risk of having a hysterectomy if there's excessive bleeding at the time of the operation. But if, for example, you have been trying for some time to get pregnant and it's not been successful, and you've had detailed scans that have shown that the fibroids are likely to be having an impact on the chances of getting pregnant, then I would say that you should go with the doctor's recommendation in that case. Hormonal balance issues, if you did want to delay the surgery, you could potentially try and get those addressed and then see what happens. But having the myomectomy on its own is not, as we said, it's not going to affect your chances of getting pregnant. It might actually improve your chances of getting pregnant.
Great, great. Thank you so much. I love the way you answered the questions. Very, very comprehensive. So thank you very much. So any other questions? Finally, going once, going twice. Okay, great. So I think that's it. Someone is asking how often we do have seminars. So we've been trying to do them kind of monthly. What I will do is I will let you know when the next one is. We're still deciding on the topic. But if you have any suggestions for topics around fibroids related issues that you'd like us to cover in the next session, then please do let us know, and then we can arrange that. There is a feedback form that will pop up after you leave the webinar, and once you leave the webinar, if you can fill out the feedback form, it's just like 4 questions, and one of them is asking what other topics you'd like us to cover in these webinars. So you could certainly do that. And thank you all for your positive feedback. People have said your presentation was awesome, so that's great. And somebody said it was very informative. And someone said that you did a great job, very informative, very knowledgeable. So thanks. So they're saying thank you. So we appreciate all the positive feedback. And like I said, if you have any questions after the session, like a question comes to mind, you can email it to us at info@lakehealthandwellbeing.com, and then I will put it to both Dr. Bryan and Dr. Illah afterwards, and hopefully they'll give a response. So that's it. Thank you so much. So enjoy the rest of your day, everyone. We will get back to you around the next webinar, what the topic will be for the next webinar. All right, then take care. Bye, everyone.